guest lectures on cannabis addiction, opioid, and physician wellness. In his groundbreaking 2023 book, Seeing Through the Smoke, a cannabis specialist untangled the truth about marijuana. Dr. Greenspoon provides meticulously researched, evidence-based examination of cannabis, its history, risk, and therapeutic potential. By weaving together medical data and cultural insights, he dispels myths and offers clarity for policymakers, clinicians, and patients alike. Today, he joins us to discuss from farm to bedside, clinical application of medical cannabis. With this unique expertise spanning patient care, medical research, and regulatory landscapes. Dr. Greenspoon is the ideal guide to explore the clinical pathway, benefits, and challenges of medical cannabis. Dr. Greenspoon, the floor is yours.
Thank you so much for that generous introduction. I'm just going to try to share my slides. Um, Here, share, send request. I have to send a request to share. So I think you guys have to approve my request, which is kind of funny. I could wing it without slides, but it would be better if I could share with slides. The host is not allowing.
Now
Oh, here
you
we
can
go.
share.
I got
I'll
it.
make you.
Nope, we are good. You have allowed me to share, which I appreciate. So let me just get the right slides. Okay. So actually I'm gonna try to move everybody over so I could actually see what I'm doing. Let me do slideshow, play from start. All right. So as you already mentioned, wait, why is it not letting me advance my slides? There we go. As you mentioned, I work at Harvard Medical School. I am a primary care doctor at an inner city clinic, which is not the easiest job on the planet. And I also work at the MGH, Mass General Hospital Addiction Clinic, which is also not the easiest job in the world. And I've been treating people with medical cannabis for about a quarter of a century. So I feel very comfortable with this topic. You know, the evidence base changes, our skill level changes. And unfortunately, a lot of the doctors, at least in the United States, but I think this is pretty much a problem worldwide, are very far behind the patients in terms of how to use cannabis, how it helps, and how to alleviate symptoms. And um, it makes it difficult for patients and doctors to have conversations about cannabis because the doctors just don't feel comfortable because they haven't been taught much about it. And you know what they've been taught in medical school isn't really very clinically applied or balanced. So I'm always happy to talk about the nitty gritty, um, nuts and bolts of treating patients with cannabis. Um, I just want to remind everybody that, I did want to talk briefly about my brother Danny. This is part of how I got interested in medical cannabis. When I was a little kid, when I was like 5 years old, he developed leukemia. And my parents, during the last year of his life, when I was like 8 years old and he was like 16, this was in the 1970s, right when Richard Nixon was starting his war on cannabis. They illegally purchased cannabis from my brother Danny, and it made such a big difference with his chemotherapy. When he wasn't taking cannabis, he was lying alone in his bedroom, just throwing up into a bucket. And when he used medical cannabis, he could eat, he could maintain weight, and most importantly to me, as an 8-year-old, he could come down and play with his little brothers. So I saw firsthand as a kid that medical cannabis is a medicine. So that sort of changed my perspective going through medical school residency and then for the last 25 years as a primary care doctor, because I know for a fact that I saw firsthand that cannabis can, not for everybody, but it certainly can have a lot of healing potential. um, I just want to remind everybody that in many countries, and especially in the United States, cannabis used to be well approved medicine. It was put in the U.S. Pharmacopoeia, the list of all the active legitimate medications in the 1850s. And in the late 1800s and early 1900s, more than 100 medical papers came out talking about the different therapeutic benefits of cannabis. and you can see Park Davis and Company. This is a subsidiary of Pfizer. And, they just used to have these extracts, these tinctures, which we use today, which we'll talk about, that you put under your tongue, and it really helped alleviate all kinds of symptoms. So I always like to, I did want to mention just a little bit about like the evidence base of cannabis. This is a topic for a entire talk. But there's randomized controlled double-blind trials, which is like the gold standard, but is very expensive and very hard to do with cannabis because it's hard to blind people because cannabis is psychoactive. They're having the same problem doing these studies with psychedelics. So instead of randomized controlled trials, a lot of the evidence base that we rely on for medical cannabis is derived from non-interventional studies, registries, electronic records, and insurance data, including patient-recorded outcomes. For example, medical cannabis is legal in 38 states in the United States. Of course, it's crazy that it's illegal still in 12 states. But they have incredible data. There are like 4 million medical cannabis patients that are registered. And we're getting great data on how cannabis can help with pain, anxiety, insomnia. For example, this is at Harvard Medical School at McLean Hospital. A great Mind is the it's a great neuroscience marijuana research group at McLean Hospital, and they show, you can see down here, they show dropping anxiety and depression, dropping pain, and dropping opiate use. And this is real world data. This isn't like randomized controlled trials, but there really is a wealth of evidence for all of the uses that we're going to talk about. And some of them are still controversial, and the patient experience of benefit is a little bit more advanced than the physician acceptance of medical cannabis as a therapeutic option. A lot of that is because of the war on drugs and all the nonsense that was just promulgated by like the United States government, and also by the addiction people haven't really got marijuana right from the very beginning. So that's sort of a work in progress. Before I talk about benefits of cannabis, because I don't want to sound like I'm an advertisement for cannabis. I'd like to go through the harms very quickly. This isn't a great slide. We're worried about teens. We're worried about their developing brain. We recommend just say wait for teenagers. People have to store the cannabis very carefully because there's a increase in overdoses, for example, of kids or just unwitting people taking poorly marked gummies and ending up in the emergency room. Driving, it's not recommended that people drive under the influence of cannabis. We don't think it's safe for pregnancy or breastfeeding, and it's not recommended. Um, the smoking isn't very good for you. We recommend tinctures or edibles. We'll talk about this later because cannabis smoke, not as bad as tobacco smoke, but cannabis smoke does have dangerous, unhelpful combustion products. It hasn't been linked with emphysema or lung cancer yet, but if you're smoking something with unhealthy combustion products like carbon monoxide, it can't be good for your heart and your lungs. There's increasing concern, especially with high dose of cannabis, that it can trigger arrhythmias such as AFib, atrial fibrillation, and even coronary events, especially if smoked. So we use it cautiously in patients who have coronary disease. Many of you have heard about cannabis hyperemesis syndrome, where for most people, for people with nausea and vomiting during chemotherapy, like my brother Danny, it really helps alleviate nausea. But heavy cannabis users who use it every day can have a paradoxical reaction and can have these very awful vomiting syndromes that land them in the emergency room. So um, there is a concern about vomiting syndromes. Psychiatrists will say that cannabis is associated with anxiety, depression, and suicide. Therefore, cannabis causes anxiety, depression, and suicide. And I just don't think this is fair or a good argument. Antidepressants, Prozac, Zoloft, sertraline, um, you know, uh, all of these antidepressants, Remeron, are associated with anxiety, depression, and suicide because depressed people use them. So, of course, they're associated and they help alleviate the symptoms. And I think that's largely true with cannabis. And it's just not fair to blame cannabis. I treat people a lot for anxiety and depression, and they overall do really well. Um, there are medication interactions, particularly with CBD. CBD, like grapefruit juice in the same way, can inhibit or compete for the same liver enzymes and can raise the level of other drugs in your bloodstream. So when you give people, especially high doses of CBD, and they're on medications like blood thinners, anti-epileptics, immunosuppressants that have to be within a narrow therapeutic range. You just want to be careful, and this is why we like to have very open, transparent communication between doctors and patients, just to avoid medication interactions and to look out for any of these complications. The final thing is addiction. People do get addicted to cannabis. Any drug that can cause euphoria and relaxation can cause addiction. It's not as addictive as alcohol, opiates, or tobacco. The nature of the cannabis addiction can be really disruptive for people, especially young people, but it's not life threatening like opiates or alcohol. So we just have to put this all in perspective. Whoops, I'm trying to advance the slide. So, in brief, who should not use cannabis? Very briefly, it is teens, pregnant mothers, breastfeeding mothers, and certain psychiatric conditions. Psychosis is a condition that cannabis can trigger or worsen. So, we don't recommend it in people with not only a history, but a family history of like schizophrenia or bipolar, or if you're going to use it, you have to use it with extreme caution. Okay, now that we've discussed potential harms of cannabis, so this is officially not an advertisement for cannabis use. We're going to talk about the clinical benefits that my patients and many millions of other patients have been enjoying for the last 25 years. They asked me to talk about patient eligibility and indications and administrative methods and dosage strategies. So we're not going to have a lot of time to go into the evidence base um, uh, because it's just that's too overwhelming. That would make it about a 24-hour long lecture and I would bore you guys to death. So we're going to talk mostly keep it clinical. So administration methods and dosing strategies. I didn't even make a slide about this. It's very simple. Many people smoke it. We don't recommend that people smoke cannabis because of the dangerous and potentially harmful combustion products. But at the same time, most people smoke it because it provides immediate and just very satisfying alleviation of the symptoms. For example, if you're going to vomit because you're on chemotherapy, you could take an edible. Nobody wants to eat anything anyways when they're nauseous. And if you take a puff, it makes the nausea go away in like a minute. Or you have a migraine. With migraines, oral medications don't work that well. You take a puff, it goes away. So we can understand why people smoke cannabis. They also have these vape pens that are very convenient. I think they're a little bit irritating to your lungs that people use. And again, unfortunately, that's what most people do because it's really effective. But we do recommend that people don't smoke cannabis, that they use an edible or a tincture or one of the other methods that we're going to talk about in a little while. Um, when you smoke cannabis, as I mentioned, it works immediately, which is great. It only lasts for like 2 to 3 hours, the symptom relief. So if someone has trouble, for example, sleeping through the night, they'd want to take an edible, which lasts for 6 to 8 hours. They wouldn't want to smoke cannabis, which only lasts 2 to 3 hours, and when they would just wake up in the middle of the night again. So smoking is more not something that any doctor recommends, but we do have to come to the recognition that smoking and vaping are what most people do. Now, again, cannabis smoke has not been associated with lung cancer or COPD or emphysema, but it does cause this irritant bronchitis in your lungs, and it's just not great for the lungs. But again, it's not as bad as cigarette smoke, and we have to put this all in context. The other context we have to put this in is, is smoking cannabis worse than whatever else you'd be taking? Opiates, gabapentin, benzodiazepines, or potentially nonsteroidals, which kill 10,000 people a year from heart attacks and they kill your kidneys. I have so many patients that take Advil, ibuprofen, Aleve, diclofenac, and their kidneys are slowly dying from taking non-steroidal after non-steroidal year after year. So again, when we talk about the harms of cannabis, you have to put it in context of like what else would the patient be taking. The administration method that I really like is the tincture, which I had a picture of a little bit earlier. This is like how it used to be 100 years ago, these old medicinal tinctures. You put the tincture under your tongue. It kicks in more rapidly than edibles. An edible will take about an hour to kick in, 45 minutes to an hour. A tincture will kick in like 20 to 30 minutes. And it lasts longer than simply smoking. A tincture kicks in 20 to 30 minutes and it lasts for 4 to 6 hours. So I think for insomnia, for chronic pain, for many conditions, the tincture is a very ideal way to steer patients. Other advantages of tinctures are the dosing is very easy. Instead of trying to mangle a 5 milligram gummy into 3/4 so you could take 3.75 milligrams of a 5 milligram gummy, A tincture, you just read the instructions on the bottle, 1 drop, 2 drops, 3 drops. You can control exactly how many milligrams of THC you get. And we usually dose this based on THC because that's the most effective active ingredient. And that's also the psychoactive ingredient that causes the most side effects. So with a tincture, you could really slowly, we like to, in clinical situations, start low and go slow so we don't overshoot. Someone new to cannabis takes too much cannabis, it can make them very anxious. We want to really go slowly and just get up to the right dose without overshooting. And a tincture makes that very easy because you could use 1 milligram of THC for a couple nights, then 2 milligrams of THC for a couple nights, and then 3 milligrams of THC for a couple nights. And for some people that might work. Some people have to get up to 10 or 15 milligrams. But the point is, we're going up very slowly in a controlled relationship. And A, we're not going to overdose and get anxious. And B, we're going to get to the lowest effective dose like we like to do with every single medication. And then the third advantage of tinctures is that you can get them really easily mixed with other cannabinoids, CBD, CBG, CBN. People use CBN for sleep. CBG is good for pain and for colitis symptoms, but mostly CBD. People use CBD alone by itself for pain, anxiety, and insomnia. And it's also a FDA approved medication for childhood epilepsy. And I find that the THC and the CBD work really well together. In fact, there's some evidence that CBD can help mitigate some of the side effects of the THC, like the short-term memory impairment. So with the tincture, you patients can get, for example, 4-to-1 CBD to THC. Then they take 2 milligrams of THC, they get 8 milligrams of CBD. They can work their way up on the two together, and it's just a very healthy and easy way to get people on medical cannabis. Of course, to get them on the tincture, you have to get them to not smoke, which is not always the easiest thing because people really like smoking cannabis. But a tincture is a wonderful, effective way to get people up on medical cannabis. I don't have a picture of this, but the next is an edible. You can imagine what a piece of chocolate looks like or a gummy bear looks like. It's not that difficult to envision. The disadvantage of edibles are that people eat them unintentionally. Like a little 4-year-old sees a bag of gummies and they're going to eat the whole thing. That's the job of a 4-year-old. And they can end up really, really sick and in the emergency room. So people who have gummies or chocolate have to lock it up or hide it like they would their Percocet or their benzodiazepines. And people don't always think about that because they're just gummies, they're food. But I think that that's one disadvantage. And the other disadvantage of edibles is that they do not act quickly. You think of smoking that acts immediately. You take an edible, a gummy or a piece of chocolate, or you bake it into a brownie or even a pill. You can buy a marijuana pill. It takes 45 to even to 75 minutes to kick in. So it doesn't give you immediate relief. The other side of that is that edibles last much longer. They can last for 6 to 8 hours. So example, if someone has around the clock chronic pain, instead of smoking every 2 to 3 hours, which is bad for your lungs and kind of very inconvenient to have to be smoking all the time, you can just take an edible 3 times a day and get really good symptom relief. For some people, we use a combination of edibles and smoking. For example, if people have really severe chronic pain, in the same way in the hospital, we'd use long-acting morphine to take the edge off the chronic pain. Then for spikes in pain, we'd use a little bit of immediate acting morphine. So we take the edge off with the long-acting morphine, and for any immediate breakthrough pain, we'll use short-acting immediate relief morphine. With cannabis, we could use edibles that last for 6 to 8 hours to take the edge off the pain or the nausea or the anxiety. And then if there's breakthrough symptoms, you could take a puff off your vaporizer. Again, we don't love smoking, but for really sick people, this is a really good way to do it. And it lowers how much smoking they need to do because they're simply smoking occasionally for the breakthrough pain, and we're taking care of most of the pain or the other symptoms using the edible. There's also topicals, CBD topicals, THC topicals, or ideally a topical with THC, CBD, and the acidic version of CBD, CBDA, which is a very powerful anti-inflammatory for joint pain, for back pain. These topicals are really, really effective. They don't work for like deeper pain. Like if you have a pinched nerve in your spine, and you have sciatica, there's no way rubbing an edible on your back is going to permeate all the way into your spinal cord and make the sciatica go away. But if you have like an inflamed joint, you can rub a topical on it and get some really good symptom relief. And the advantage of topicals, you don't smoke them, you don't metabolize them, they're not psychoactive, they don't get you high, there's no blood levels, they don't interact with other medications. So if you could get away with a topical, that is actually the best thing that you could do. There are all these other if you go to a dispensary, all these other delivery methods, which we're not going to talk about today, but they're like inhalers, they're skin patches, they're little spritzes, and some people really like the use of suppositories. People with vaginal symptoms, pelvic symptoms, endometriosis. The idea with the suppository is put the medicine where it needs to go. And it's thought you can get very high local levels, like in the pelvic area, and don't get as high as much psychoactive effect because you're just putting it locally. You get some, it's in your blood. Or if someone has like ulcerative colitis and they have a lot of like pain in their lower colon, you could use a rectal suppository and really help people with their symptoms. So there are a lot of different administration methods. The most common are smoking, either with a joint or a pipe, or vaping, or using a dry herb vaporizer, which is great. You just heat up flour. That's even safer than the vape pens. There are tinctures, which I personally favor, and then there are edibles, and then there are a lot of topicals and a lot of other ones. So those are the administration methods. The dosing strategy I alluded to. I only have half an hour here, but we start low and we go slow. I start with just elderly patients, 65 and above. I'll start with 1 milligram of THC and then maybe like 4 to 10 milligrams of CBD in a tincture. And I'll go up to 2 in a couple days. Then I'll go up to 3 milligrams in a couple days. If a younger patient comes in and they have pain or anxiety and they say, yes, I used cannabis in college, I had no problem with it, no side effects, then you start with 2.5 and can go up to 5. You can titrate it up more quickly if people are younger, if they're on a less complicated medical regimen, or if they've had experience with cannabis. You know they're not going to have a bad experience and freak out, assuming that they start low and go slow. But again, you don't have to start as low or go as slow as you would in an elderly patient or a very medically complex patient that, say, has kidney or liver insufficiency. So patient eligibility and indications. I already spoke about patient eligibility. You want to be really careful in someone with a history or family history of psychosis. Except in rare conditions, you wouldn't use it in a pregnant or breastfeeding woman. And we don't use it in teens unless A, they're dying of cancer, like my brother Danny, of course you're going to make them comfortable. Or B, there's increasing excitement about the use of mostly CBD, but with a little bit of THC mixed in for teenagers with autism. It can help with the non-core symptoms of autism, and some people think it could really help with the core symptoms of autism. So the point is there are exceptions to every rule. We don't use it for teenagers, but if a kid has autism, you could try CBD and see if it really helps them. You want to be very careful for side effects. Kids with autism, we bombard with like stimulants and antipsychotics and sedatives and antidepressants. And, at some point you just have to ask, is cannabis or particularly CBD less dangerous than all of these other medications, than Ativan, Risperdal? So again, it's all about context. And then again, patient eligibility, we're just very careful. We're more careful in older patients, even though it has tremendous potential, as I'll talk about, to help with the discomforts of aging. And we're careful with people with cardiac issues, and we monitor people for addiction when we start medical cannabis. It can be very difficult to tell who's addicted because a patient can be doing really well and also using it more than you think they could use, sort of like with medicinal opiates, medicinal benzodiazepines. Sometimes it's obvious if a patient's addicted, they're going to 8 doctors and you see track marks in their arm. Other times they're doing really well and you're not concerned, but a lot of times it's very murky. It's helping them, but you also think they're a little overly dependent on it. So addiction is another thing that we keep an eye on. So that's a little bit of a patient eligibility. I know we don't have a ton of time. We want to leave time for questions. The main things that I use cannabis for in my clinic are, for example, pain. There's particularly good evidence for neuropathic pain. In 2017, the National Academy of Sciences, Engineering, and Medicine in the United States government, which are not particularly pro-cannabis, said that there was conclusive evidence that cannabis can be helpful for neuropathic pain. Other pain syndromes that I find it very helpful for are fibromyalgia. Nothing really works for fibromyalgia, and we drug these people with all kinds of drugs and opiates. And it actually is very helpful for patients with fibromyalgia. And I actually think cannabis should go down further on the list, or up further on the list. We use it sooner than other medications on fibromyalgia. You know, the doctors are just starting to put cannabis on the list, but for something like fibromyalgia, I think it should be number one or number two on the list. Um, it's very good for the pain and discomfort and gastrointestinal symptoms of irritable bowel syndrome. Tons of people have irritable bowel syndrome, and they find cannabis to be as effective, if not more effective, than many of the traditional pharmaceuticals. And again, it all comes down to which is more dangerous, cannabis or the traditional pharmaceuticals. It depends what they're using and how much they're using. But I just think there's a lot of talk and sensationalism about this particular harm of cannabis. But you have to look, if they're using, again, cannabis instead of opiates or tons of nonsteroidals, it could be significantly safer. Anxiety is a huge reason why I use medical cannabis in my clinic. People feel that it takes away the stress. It helps them not think too much about things. It helps them be meditatively and mindfully connected to the present. It helps people connect with other people. It can be a social lubricant. It can help with social anxiety. Again, this depends on taking the right dose. Cannabis for anxiety is biphasic. At a low dose, it can make anxiety a lot better. And at a very high dose, as I mentioned before, it can give people anxiety. Like if you don't know anything about cannabis, and instead of starting at like 1 or 2 milligrams, you took 100 milligram gummy, which unfortunately they have in some of the dispensaries. So patient education is a very big part of this. They would have a panic attack and end up in the emergency room. So with anxiety, you really want to start low and go slow and make sure you have some CBD in addition to the THC that can help mitigate some of the anxiety producing effects of THC. But if you get the dosing right, it can really help people get through. Have had a lot of patients get off their SSRIs. You know, SSRIs aren't particularly dangerous, but certainly I don't think they were meant to be forever drugs. We have so many patients that got started on SSRIs 20 years ago, and we don't really know the long-term effects of being on SSRIs for like decade after decade. And you know, if a patient can get off an SSRI and use a small dose of a cannabis edible, that's a win. So again, we're getting people off of benzodiazepines, we're getting people off of SSRIs. For pain, we're getting people off of opiates, nonsteroidals. Um, and the gabapentinoids, who knows how safe or unsafe they are? They don't even work that well. So, a big theme of all this is using cannabis instead of other medications, and this could be a net win for harm reduction. I know I'm running low on time. I wanted to talk about chemotherapy induced nausea and vomiting, which I think many of you are probably familiar with. It helps people, as I talked about with my brother, eat and maintain weight. It also helps with the symptoms of cancer. It helps with the pain, the anxiety, and the insomnia. Um, Cannabis does not cure cancer. Some cannabis advocates think that cannabis cures cancer. There's a lot of folklore about this. And in truth, in the test tube, many of the different cannabinoids kill cancer cells. But if you have cannabis, find an oncologist. And if you have symptoms, either from the chemotherapy or from the cancer itself, use cannabis. But don't use cannabis to treat the cancer because that does not work. You know, I wanted to mention, I already mentioned autism, multiple sclerosis. It really helps people with the spasticity, and Parkinson's disease. It helps people with bladder issues, movement, and anxiety and insomnia. But the final one I want to talk about, which is a really big one, is insomnia. Tons of people have insomnia. People take really, really crappy medications for insomnia. They take Benadryl, which just works for a couple of nights and gives you a huge hangover. And Benadryl actually contributes to dementia. There's some research. They take Ambien or the other Z drugs, or they take benzodiazepines. Those are addictive. They're sedating. They affect your memory, and there's some concern that they can cause dementia, contribute to dementia as well. So if I get someone off of Ambien and onto, say, you know, a tincture with 4 milligrams of THC and 16 milligrams of CBD, or even 20 milligrams of CBD, if it's a 10-to-1 ratio of CBD to THC, that is a net win. Some people use CBD alone for insomnia. That's the net win too, because CBD alone doesn't have any of the risks or the side effects of THC. But again, many people, a combination of THC and CBD, can get off these more dangerous drugs. I would even argue that we have a lot of people on amitriptyline and trazodone for insomnia. And I would even argue that cannabis is safer than that. Of course, if someone has insomnia, you don't just blast them with medications. This is the primary care doctor in me. You make sure that they, aren't drinking caffeine all day, or getting some exercise, or doing something restful and relaxing before bedtime, which would maximize their chance of success with any of the medications I discussed. So, this is an overview of many of the symptoms that I treat with cannabis. It's now 1:31. I was supposed to speak for half an hour. I can, as you could probably tell, speak for about 6 to 8 hours on this stuff. I'm very happy to announce that on May 5th, 2016, I have another book coming out called Aging Well with Cannabis: Feel Better, Sleep Better, and Live Better with Marijuana and CBD. It is specifically about how to use cannabis in the senior population. That is the demographic of cannabis users that is growing most rapidly. People are getting it from their kids, they're hearing about it from their friends, and I just want this to be safe. So, this book is going to talk about what the indications are, what the risks are specifically for older people, and how to get people started very safely, and how to watch out for medical interactions. So, Aging Well with Cannabis, about cannabis for seniors. And then, as mentioned, I do have a book out called Seeing Through the Smoke that goes through the harms, the actual harms of cannabis. And then it also talks about the harms that the US government just fabricated as parts of the war on drugs. Like, it's not a gateway to addiction. If anything, people find it as a gateway out of addiction. They use it instead of opiates, instead of alcohol. They use it for withdrawal symptoms. It actually helps them overcome an addiction. So it talks about the real harms, the imagined harms. It talks about the actual benefits. Then it talks about the imagined benefits. As I just mentioned, cannabis does not cure cancer, but it talks about all the actual benefits, which I just spoke about. It talks about the social history, which is a very interesting but ugly, at least in our country, has been just awful. We've arrested, as part of the war on drugs, more than 20 million people for nonviolent cannabis possession, many of them just trying to use it medically. Many of them for black and brown skin. Blacks get arrested more than 4 times than whites do, even though in the United States, even though they use cannabis at the same rate. And then it talks about some lifestyle uses, how people use it to enhance their lifestyle, to enhance sex, music, art, enjoyment of other people. So, check it out if you get a chance. I'm going to skip this, and then this is just me. I'm going to stop sharing my slides, and then I'm going to I think I'm supposed to open this up for questions. I just have
Oh,
to find
thank you
the.
so much for that lovely, lovely presentation. Very informative. Actually, there are some kind remarks coming in, and people are saying how amazing you are and how they would like to read your book. And they're asking how can they get your book. But before we go there,
Oh,
I
on
want also to
Amazon.
invite.
Just get it on Amazon. It's very easy. So,
Okay, okay. Get it on Amazon. Get it on Amazon. I want to invite the other panelists also so that we can start with question and answer. If you could just show your face, some of you, if you want to. The first question goes to you, Dr. Peter Greenspan, and it says, is there clear
sorry, you froze a little
evidence?
bit. Oh, can you repeat
I
the question?
froze. Can
You
you
froze
hear
for.
me?
Now I can hear you. I just love
Can
you to
you?
repeat the question because you
Okay.
got quiet for just a second.
Okay. Is there clear evidence for use in autism, for the use of cannabis in autism?
Well, it's really interesting. When I started writing my book, Seeing Through the Smoke, in like 2021, 2022, I was a little bit skeptical about the indication of cannabis for autism, but I went through all the research and it's really, really interesting. I'm increasingly becoming a believer. Again, you use
Mm-hmm.
mostly CBD with just a little bit of THC. People use 20-to-1 ratios of CBD to THC, or 50-to-1 ratios of THC of CBD to THC, because you want to spare the teens the effects of THC, because we're a little bit worried. It hasn't been proven definitively about the effects of THC on brain development. And using cannabis, if you study the kids or you study their caregivers, can really help with the non-core symptoms of autism, like the self-injurious behavior, the aggressiveness. And there's some evidence that it could actually help with the most painful core symptoms of autism, like eye contact, a social connection. So I think this is going to be absolutely huge. And I'm not 100% convinced, but I'm largely convinced that CBD particularly is going to be helpful for kids to autism. And again, they're using CBD instead of like lorazepam or Zyprexa or Adderall or these heavy duty sedatives, neuroleptics, and antidepressants, and even antipsychotics. So, first of all, again, the question is cannabis, mostly CBD, safer or less safer than all these other medications we're like bombarding these kids with? And second, is it effective? And there's a very compelling, growing evidence base that it is effective.
Thank you, thank you. The second question goes like, how do you decide when cannabis is appropriate compared to other treatment options?
Well, that depends a little bit on how familiar you are with cannabis. I alluded to this uh, recently. Like, for example, for fibromyalgia, that pain, that poorly understood pain syndrome, we don't have very good medications that treat it. And so, like, now the doctors are begrudgingly putting cannabis like number 4 or number 5 on the list of, your diagnostic algorithm going down to treat fibromyalgia, whereas I would put it number 1 or number 2. Part of that's because I've seen it help people for 25 years, which a lot of doctors haven't seen because they don't treat patients with cannabis. And part of it is because I just think it's safer than all the other medications we use. So I use it more readily than a lot of other doctors too. But I think as we educate doctors, cannabis is rapidly going to go up on the diagnostic algorithm. Chronic pain, we used to just put everybody on opiates. Now, what do we have? We have like antidepressants, Cymbalta. We have, again, non-steroidals, which will give you a heart attack, gastritis, or kill your kidneys. Um, Tylenol doesn't do anything. Gabapentin makes people feel brain dead, and I think it's sort of an overfluff medication. I don't think it's that helpful. I think people do, not everybody. Some people have side effects, some people it doesn't work, and some people don't like the high and can't get used to it. But in general, I use cannabis fairly early in my chronic pain treatment. And again, I use it earlier than other doctors just because I'm comfortable with it. So I think it's going to get earlier on the algorithm as people get more educated about it. And again, it has to do with how severe their pain is. For example, like if they have like really, really, really severe pain, cannabis isn't strong enough. You're going to need to use opiates. And if you try something else and it doesn't work, then you might try cannabis. So it depends on how sick the patient is, what they've tried, what side effects they've had, whether you think cannabis is more or less dangerous than whatever else you'd be using, and how they respond to cannabis. So it depends on a number of different issues.
Oh, thank you so
Sorry, that
much.
was a long
I'll
answer.
ask
So,
I'll ask the third question. And this question, I'll also allow Dr. Sandra who is also a specialist on cannabis, to chip in if he has anything to contribute on the question. How do you incorporate cannabinoids therapies into broader treatments? For instance, alongside pharmaceuticals or imaging findings?
well, Sandra, I'm happy to have you take a stab at that. I mean, I'd very briefly say you do it carefully and mindfully with open back and forth communication with the patient. Make sure that they can get to you with side effects. You don't want to be one of these doctors that sees a patient and then, at least in the United States, they can't even talk to you for the next year because our medical system's in collapse and our social network is getting increasingly in collapse because of our current government. So you want to have close follow up with the patient. You want to start really low and go slow, and you want to keep an eye out for benefits. I usually have them journal how much did you try? Did you have any symptom relief? Are you having any side effects? And if you start low and go slow and watch out for drug interactions, is actually pretty safe. But I'm wondering if Sandra, who probably knows about 100 times as much as I do, what she has to say about this.
Oh, thank you. Thank you, Dr. Greenspoon. It's such a pleasure to have you here. I read your book and I love that. Thank you so much. You're a true pioneer. And definitely it's been very interesting, all your conversation, because I share with you all the points of view and the approach. As a clinician, the best way to start with the patient is just start with a small dosing, and there start titrating up. And the objectives of the treatment, sir, is achieve control of the symptoms at the minimum side effects. So that's when you start with small doses, the patient will start telling you how they feel. And if you start seeing side effects that they are really concerning you. You just lower the doses, or you see if you need to change the chemotype that you're giving the patient. It's many different tools. And sadly, as you say, sometimes where the patient is self-medicating, maybe they don't achieve the results, and they should just this is as we call it, is a medicine, so it should be through a prescription or a recommendation of a physician, of a doctor that knows and is familiarized and how the endocannabinoid system, how the titration process is, how the side effects can occur, and when the patient does self-medication, the treatment doesn't work or works badly or give them side effects, and then the patient loses the opportunity to have access to this wonderful alternative that we have in the toolbox, that I say every physician who should have cannabinoid therapies in their toolbox. So I definitely think, and in refractory epilepsy, definitely is where we have the most robust evidence, and we even have the FDA approved Epidiolex, that is the cannabidiol, the purified, and where they did randomized placebo-controlled trials and all these wonderful research. So definitely, I couldn't agree with you more in this. And as you said, cannabinoid medicine is a very personalized medicine. You have to be with the patient. You have to be doing the follow-up, monitoring the side effects. That, as you said, if you are aware, if you know how these work, is not something that you worried. Sometimes people, as you said, I get patients with a refractory epilepsy that they come and they say, oh, I'm taking clobazam, I'm taking valproic acid. So that means because there is a side effect or drug interaction, the patient cannot take it, and it's not. The studies are proven that if you start working with the doses of the benzodiazepines, lowering the doses, you can work out so the patient gets the benefits of the cannabinoids. But thank you, doctor. You were, like as usual, amazing with your presentation. And for everybody, get the book, because there's a lot to learn there.
I think this answers what you have said. Just answers our next question, which goes to that, like, how do you measure or monitor patients' progress with cannabis therapy? That is answered with what you have said. So I'll give you two more questions. The first one is, have you observed differences in outcomes based on age, gender, or condition subtype?
Oh, absolutely. Again, as Sandra just said, is very individualized. You know, for example, for anxiety, some people need like 1 milligram. Other people take like 1 milligram and they get anxious. Other people need 10 milligrams. It's very, very personalized, which is why, again, as I mentioned before, the critical components, which are critical for anything you're doing in medicine, but particularly with cannabis, is open doctor-patient or nurse-patient communication, really clear and accessible follow-up. And I often have people journal because everybody's so different. It's not like you have high blood pressure, I give you 10 milligrams of lisinopril. I have a very clear expectation of what you're going to look like in a month, and I recheck your blood pressure and your potassium in a month, and you predictably have better blood pressure. Cannabis is a little bit more unpredictable. You could call it flexible, but it's also a little bit unpredictable. So I have patients journal. I can't emphasize that enough, because nobody remembers a month later, oh, I felt good this day, I felt bad this day, I felt good with this strain, I felt that good with that strain. But if they write it down, data is everything. So I really encourage people to journal and I'm wondering what Sandra has to say, but I just think it's very personalized, and it's a teamwork. It's a back and forth with the doctor and the patient. It's not like the doctor paternalistically gives a medicine and says, see you in a year. It just doesn't work that way.
Yes,
You touch on a
absolutely. Absolutely. I
go,
just
Sandra.
want to add a little thing regarding to journaling for the patient is very important. For also for the clinician to record properly in the clinical records is very important. For example, I use a lot in my clinics, like the scales, like a scale. They are a lot of validated scales, like a pain inventory, quality of life. And it's amazing when you see when the patient showed up, the first time, and you show them, because these are like numerical scales or scales. They are more like that you can visualize the improvement. It's not the same when the patients came with a pain 10 out of 10, and then you show them like 4 months later, 6 months later, that the pain is 4 out of 10. And sometimes when the patient is already being like with a very low pain for 1 year, they forgot how bad they were. So when you show them the scales, the same with quality of life, it's amazing. So it's like, as you say, journaling for the patient, but the physician has to record all these tools in the clinical history. Very important.
Absolutely. And if I could just add, you mentioned health-related quality of life. If you look at all these studies, that's the thing with cannabis that most consistently goes up. And when you think about it, what's more important than your health-related quality of life? I mean, your health is everything, particularly for older patients, which is what my next book is about. It's all about the health-related quality of life. So Sandra's absolutely right. And that is what goes up in all of these studies.
Oh, thank you so much. Thank you so much. The next question goes like, do you track side effects or interactions with other medications?
Well, absolutely. Again, with CBD in particular, I'd be interested what Sandra has to say with this. You have to watch the liver enzymes if you use high doses. And again, it works just like grapefruit juice. It competitively inhibits the enzymes, so you can get higher levels of other drugs. For some drugs, it doesn't really matter so much, but other drugs have to be within a really narrow therapeutic window, like again, immunosuppressants, anti-epileptics, blood thinners. You want to just monitor. So I monitor the patients clinically carefully. Occasionally, you might have to draw extra blood tests like liver tests or check an INR if they're on Coumadin. And again, with the side effects, it's all about open communication. If a patient says, I went up to 4 milligrams and I feel anxious, I'll be like, let's go down to 3 milligrams. And cannabis doesn't work for everybody. No medication works for everybody. So, sometimes people get really disappointed, but sometimes there's no magical level where they can get symptom relief, but they don't have side effects. So you're really trying to, as Sandra said, use the lowest possible effective dose so that you could maximize symptom relief and minimize side effects. But it all comes down to open communication between doctors and patients and really clear follow-up, which and the follow-up can be very difficult in the United States medical system. It's hard to get in to see your doctor. A lot of people can't find doctors anymore, but that just makes everything more dangerous. But people, and there's also stigma still about cannabis. Again, it's still illegal in 12 states for medical use. So we just have to encourage, like if a doctor can talk about any drug or medicine with a patient comfortably, that can help save lives. If I can talk to you about your opiate addiction or your alcoholism, that will save lives. And in the same way, doctors have to feel really comfortable talking to patients about cannabis. And that's the best way to get people to open up about any problems, addictive symptoms, or other side effects they may be having. Oh, I think you're on mute.
Dr. Tenba, we cannot hear you. You have to unmute yourself. Dr. Tenba?
Okay, sorry. Dr. Carrillo, do you have anything to add on that, or should I ask the next question?
Well, just a brief thing. I agree with what Dr. Greenspan is saying. Definitely, I mean, we're talking about medicine and it has side effects. Tylenol has side effects, and definitely since cannabinoids like CBD are metabolized through the liver, through the CYP 450, we are going to be looking at drug-drug interactions. And this is not something to be fear or to have fear of, because sometimes the doctors don't want to prescribe it because they say, oh no, there is a lot of drug-drug interactions. Because when you see there is a list of drug-drug interactions and it's growing every year, but it's not for being afraid. It's just for, if you know that there is an interaction, well, you know how to manage the patient. And definitely also we have to remain cognizant that the cannabinoids share profiles of side effects with other medication. For example, as Dr. Greenspoon says, some benzodiazepines, they cause sedation. Well, THC cause sedation. So these profiles of side effects are shared, so you can potentiate the side effects, but it's not to be afraid of. It's just knowing, so you know that you will reduce the doses or one or of the other one. So it is like That's what is so important, to have these spaces of education and classes like with Dr. Greenspoon gives today, because it will give us a light to know that it's a safe. Cannabinoids are safe. It's just you need to know how they work and the pharmacokinetics, pharmacodynamics, drug-drug interactions, and is that way you will have like a safe clinical practice.
Thank you so much, Dr. Brillin. Welcome, welcome. Do you have anything to add on, or should I ask the next question?
Well,
Just
there's a little bit of a double standard with cannabis, because people are like, oh no, there are all these drug-drug interactions, but any medication I prescribe has just as many drug-drug interactions, and you pay attention to them and you're careful of them. But somehow when it's cannabis, this is like a scary, awful thing. And if you read about, whatever, Prozac, there's like a million drug-drug interactions too. So I agree with Dr. Carrillo. He's just nothing to be afraid about. It's just something to be aware of, like we are with any other medication that we prescribe.
Right.
thank you so much. Thank you so much, Dr. Greenspoon. Lovely having you on the program. And as always, we've met in the US before. And thank you so much. I think from our side, I'm actually in South Africa, more on the cultivation side. Apparently, I didn't know there was actually a Dr. Greenspoon strain. Could you
Yes.
tell us a little bit more
Well, it's
about
named
it?
after my dad. My dad was a very legendary cannabis specialist. He wrote a book in 1971 called Marijuana Reconsidered, calling for legalization. At that point, only 12% of Americans supported legalization. Now it's up to about 70%. It went up about a percentage point for each of the 50 years that my dad worked on it. His book was reviewed on the front page of the New York Times Book Review, and he really provided a lot of the intellectual firepower for the legalization movement. He also wrote a book in 1993 called Marijuana, the Forbidden Medicine, which was like a guidebook for doctors and patients to use marijuana, which paved the way for the 1996 California legalization of medical marijuana. So, in recognition of my dad's half a century long efforts towards cannabis legalization and education, there's a strain which I have to say is a great strain. It's very cerebral and very energetic, called Dr. Grinspoon, named after my dad.
So the next question is, how do we get hold of it to try and plant it in the Southern Hemisphere and see how it's going to work here? How do we get rid of or get hold of that strain?
Well, I think it's pretty easy to get the seeds online. I know Barney's used to sell the seeds online. I don't know if they still sell them, but I think if you were to just Google Dr. Grinspoon marijuana seeds, it would be pretty easy to find them.
But I think it's also important. We've got you on the platform. We would like to see if we can get directly from the source, from yourself.
Oh yeah, I don't have any seeds. I don't grow it. I don't have any. I've tried
So
it.
where's the IP of the seeds? Who's got the rights to the seeds?
I
Do
don't
you own the
know who
rights
has
for the
the
seeds,
IP.
or?
It was just a really smart, there are these really smart cannabis scientists, and a really smart one that was a friend of my dad's. I don't even know who it was, created the Dr. Grinspoon strain. I don't think anybody in particular has the IP, and I think it's sort of like open access, and I think you could just get the seeds online. I just don't know if anybody or that anybody has the particular IP. Nobody has a patent on Dr. Grinspoon. Just like nobody has a patent on like Durban poison seeds, right? It's just a strain that everybody uses. So
That's an interesting one, because we've been talking to our regulatory authority and the Department of Agriculture, and we have actually requested that we register the Durban poison officially, because I think the Dutch guys have done that, but then it belongs to us here in South Africa. So that's actually very interesting. I think it's something that we're very much interested in, because it's part of this farm to bedside where we start registering some of these seeds. So it's quite interesting that to note that you're saying that maybe nobody's got the IP and so forth. So it's something that we at our Paso Farms here in South Africa and with the Global Health Catalyst could look at actually the Dr. Greenspoon as a start, and then maybe we can actually register and have the IP of it and see how we can move forward with it from farm to bedside.
sounds great. I do want to qualify that I'm the last person who knows about IP or issues like that. It's definitely not anything I know anything about. So
No,
On
thank
to the
you.
next question. Some very kind word from Arthur Juang. Dr. Arthur Juang says that was a very excellent presentation. And so many thanks to you, Dr. Greenspoon. So his question is there any indication of the use of medical cannabis for intractable epilepsy?
Well, there is in kids. There's great evidence. That's why, as Dr. Carrillo said, there's FDA-approved medication, which is CBD, for intractable epilepsy syndromes. There's a couple childhood intractable epilepsy syndromes, Dravet syndrome. Um, people started using it. Like Charlotte Figge was a kid who started using it, and there were these like incredibly compelling videos of her seizures just stopping. And this is a kid who like nothing else worked. So the FDA couldn't ignore these videos of like the seizures just stopping, and they had to pursue it and study it. And now we do have an FDA approved medication for childhood epilepsy syndromes. There's good evidence, and I wonder what Dr. Carrillo has to say about this, that epilepsy in adults can be improved with CBD. I don't think it's used right now as monotherapy, but I think it could be used very effectively with other anti-epileptics and potentially to help with the side effects of the other epileptics and to lower the doses of the other epileptics and to lower the seizure frequency in treatment resistant epilepsy. So I think it's used in adults as like part of these drug combinations, but not part of monotherapy yet, like it is in kids. But I wonder what Dr. Carrillo has to say about this.
Yes, Dr. Greenspoon, I agree with you 100%. This is, and actually in a lot of the countries all over the world where they legalize medical cannabis is because of epilepsy patients. The big majority are mothers that they're driving to the Congress, talking to the legislators, asking them to legalize medical cannabis. And I've seen the example in different countries, for example, in Brazil, in Colombia, in different parts of the world. It was epilepsy, the one that gave the first step. The patients with the epilepsy, the children with epilepsy, the mothers asking for legalizing medical cannabis. And absolutely, we have also patients, adults, with refractory epilepsies or epilepsies that are very refractory to management. And usually the indication that is approved by FDA, as Dr. Greenspoon says, is intractable, or what they call refractory epilepsy, is the patients that they already tried 2 or 3 medications and they don't work. As he said, it's not like a monotherapy. It's not that when a patient comes for first time with a seizure, they haven't been studied with a neurologist, then we're going to give them cannabinoids. That's not the procedure. We have to just do a proper diagnostic, a study, and it's not the first line treatment for epilepsy right now, but it's a very, very good alternative because 30% of the epilepsies are refractory. So definitely is a very big number to consider.
I'd also add there's tremendous interest among neurologists in studying CBD for this indication. What a doctor thinks about cannabis depends a little bit on his or her vantage point. The oncologists, 90% of them are in favor of it because they see it helping so many of their patients. On the other end of the spectrum are the pediatric and adolescent psychiatrists who see the rare but very tragic cases where cannabis can contribute to psychotic disorder in a young adult, and they tend to be very anti-cannabis. And because CBD is so interesting in epilepsy, you see the neurologists getting more interested in it every year. So I think there's going to be a lot of studying of CBD, and a lot more good data should start to come out pretty soon.
Thank you. Dr. Greenspoon, I just want to make a request to you. So our next presentation was supposed to start, but I've been given a grace of some few minutes. The next presentation will be uploaded because it's a recorded presentation, will be uploaded on YouTube. And for anyone who has questions, they will be asked to direct the questions to the presenter. But for now, do you have a few minutes for us for me
Yeah,
to?
absolutely. I'm happy to keep going. This is fun, and it's an honor to be with Dr. Carrillo. So I am happy to keep going.
Great. How can age, metabolism, and genetics influence cannabis suitability and dosing?
Well, you don't know. So that's why you have to start low and be and go slow. With age, it definitely, you know, people, they age, they're on more medications, they have polypharmacy, there are more potential drug interactions. This is what my new book's about. You know, their livers don't generally work as well, their kidneys don't work as well. I mean, you know, you take any 75-year-old and compare them with a 25-year-old, their liver and their kidney just aren't going to work as well, and they're going to be on a lot more medication. So you just have to be more careful in older patients. Now, in terms of genetic differences are, you know, an issue for every medication that I prescribe. But I don't actually know. It's just the beginning of being studied, you know, how this going to affect with a particular patient. So I think that that is a very important issue that doesn't really come up that much clinically, because if someone comes in as a new patient, I don't know their genetic profile or what how their genetics are really going to affect the cannabis that I prescribe. So I think genetics are going to be huge, but we're just starting to study that even with other drugs, and we're even as ever always behind with cannabis. So I think that's going to be very important, but to be determined. I wonder what Dr. Carrillo has to say on that.
Totally agree with you, Dr. Greenspoon. Definitely, there is talking about genetic testing. There is some tests that you can do to the patients, and they can detect some polymorphisms, and they will tell you if the patient is a fast metabolizer, slow metabolizer. But it's actually it's not that used in the clinical practice because they are costly, and sometimes the patient don't want to pay for them. I think for the future it will be interesting. There is a lot of pharmacogenomic testing in psychiatry to see when a drug is working for a patient or not. I think genetic testing has a future, but for now, I think it's a tool that because of the costs are not that easy to access for the patients, and also the value will be just in very specific cases when you see that a patient is not responding or is having maybe a reaction that you cannot explain. But definitely, genetic testing will be like a big value for the future. But right now, I think the costs are a little bit restrictive for the patients.
And I want to add one thing. There are some people that are offering genetic testing, and they say, this is your genetic profile, this is your dose, and this is the strain you should use. And I think that's absolute complete nonsense, that these people are sort of predatory. They're like, I don't want to be critical, but they're sort of like implying that we're much further along with the genetics than we are. And they offer this expensive testing, as Dr. Carrillo says, it's expensive, but you can't look at someone's genetics and say, therefore, you should use sour diesel. I mean, it's absolute nonsense. So I do want to say that with the cannabis industry, like with any other industry in the world, there's a sort of predatory component. And that's one area where I've seen sort of really sort of unethical things where they test your genetics and say, okay, then you could use, you know, cookies and cream strain for your anxiety. It's just nonsense. So I don't think we're there yet.
Okay, I see Dr. Flores up, please. Dr. Flory,
Yes,
would
I
you?
just wanted to have a follow-up question on what has been just asked and discussed now. My understanding is we have different strains of cannabis, right? And I guess certain strains grow better in certain parts of the world compared to other parts. My question is, have you seen a specific strain best responding in a group of population? And is there any correlation with like strain versus response clinically?
Well, I'm going to mostly defer this to Dr. Carrillo because in the United States, there are so many strains. There are thousands of strains. Each marijuana dispensary has their own strains. There's so much nonsense and false claims about all the strains. All the strains have the same description if you look at them. I mean, I'm simplifying a little just to be humorous, but they all say causes an initial rush of cerebral relaxation followed by a full body relaxation. And then furthermore, the strains aren't consistent. Sour diesel in San Francisco is completely different genetically than sour diesel in Boston. Or if you go to two different dispensaries and you get sour diesel, they're like different products. There's no regulation or consistency. So I think theoretically different, we use the word chemovars, what actually is in the cannabis, are going to help alleviate different conditions differentially because there's so many different psychoactive or medicinal components in cannabis. But I don't think, at least in the United States, we're at the point where you can use this strain for this thing. If people find a strain that works for them, that's great. They should stick with it. But there are also predatory people in the United States that have these apps where you put in your symptoms and they tell you what strain, and they're actually working with the dispensaries. And it's all about making money for the people with the apps and for the dispensaries. And it has nothing to do with alleviating clinical symptoms. So I don't think we're there yet, at least in the United States. But I'd love to hear. But there's a real hypothetical potential for this. We need a lot more standardization and regulation. I wonder what Dr. Carrillo has to say.
Yeah, absolutely. In Latin America, we use more the oral administration as a therapeutic way. Definitely, we use chemobars, chemotypes better, like chemotype 1 being like predominant with THC, the chemotype 2, the balance, that is the 50-50, let's say it's CBD THC, and the chemotype 3 is the predominant in CBD, and then they're calling now chemobar, chemotype 4, the CBG predominant, and then the chemobar 5 is with other cannabinoids. So with this classification, we move around with when we're using in Latin America the oral presentations. I think that these names, the sour diesel and all these other names, are more used when you're using flour. For now, our legislation don't allows us to prescribe flour, but we're gonna get there, and I think we're gonna be facing the same challenges that Dr. Peter is facing, because people tends to just want to go and they familiarize with the names, but at the end, when we are teaching I teach in different universities, what we tell the students is that these names, they really don't mean that much when you are prescribing. You go for the chemobars better, the content of CBD and THC when it's oral presentation. Of course, when it's inhaled route, you think about terpenes and all these other things, but yes, it's a challenge.
Just of interest as well, Dr. Sandra, you mentioned that in Panama, you're not allowed to prescribe flour. Is that correct?
In Colombia, we're not allowed to prescribe flour. In Panama, the legislation is going to allow to prescribe flour, but is not implemented yet. Still nothing, nobody's having access to anything, because the government is taking their time into implementing
Well, in South
the law.
Africa, it's a different story altogether. We've got what they call a Section 21. So you can go and visit your doctor, say you've got multiple sclerosis, and you allow the doctor then writes a motivation to the regulatory authority to say you got MS, and they can actually prescribe the flour, and they can say which farm you can source it from, and you're allowed to buy smokable flour on a script. In South Africa, that's how far they've gotten now. But also, just to touch back on both what you've both said as well, I think there's a lot more research that's required into all this that we're talking about. And I think we have made a few headways in South Africa, but then again, now we are at a level where we've got the products, we've got everything, but we need to now submit the dossiers. And the dossier is very expensive to do. And also we need to get the subjects, the patients, for the research. Like, for example, we're setting up for post-traumatic syndrome disorders and some on HIV and the likes. And you need at least about 20, and then do a randomized case study and so forth. This in the clinical setting, but we still kind of like hanging. So I think there's a lot more that's needed to be done for us to actually move forward with this. But I think if we keep pushing on platforms like this and a lot of expertise, the likes of yourselves, I think we'll make headways, we'll get somewhere. So yeah, that's what we've got here at the moment. And then again, on the continent, we've only got about 9 countries that have legalized medicinal cannabis. So again, the education is of paramount importance, educating the world about the medicinal cannabis, what it means and what it is, so that we dispel the stigma around it, because then, of course, you know, people they smoke it, they do all sorts of things, but nobody wants to know that your neighbor is smoking. So they go under the table and so forth, and they're sick, they go to the hospital, they come back, they put the tablets in the cupboard, and then they use the medicinal cannabis, or cannabis rather, even the landrace strains. And we know it works, but what is actually working? Like you rightly said earlier, Dr. Greenspoon, that standardization and dosaging, and then of course the safety and efficacy and so forth and the likes. That's what we need to really push on. And thank you so much for all this input, and I'm sure all our viewers as well are following on this, and all of us together collectively, we can do it. Look, we got somebody in Panama, we got in the US, we're here in South Africa, so we are bringing the whole globe together, and that's what the Global Health Catalyst is all about. Thank you.
Thank you. Thank you, Dr. Brilliant. I think that addresses also part of the next question, which says, what research do we need to focus on to determine how cannabis can benefit cancer care?
First of all, we need research on the potential of cannabinoids to kill cancer cells. As I mentioned in the test tube, they really kill cancer cells. It's really pretty remarkable by a whole variety of different mechanisms. This leads people to believe that cannabis kills cancer. That is not ready for showtime, but I think it would be really interesting to study if cannabis can ultimately help with cancer. With cannabis, we need more research on the harms. We need more research on the benefits. We need more research on the different chemovars. We need more research on how to use it clinically. It's all in its infancy. Now, keep in mind that we're just coming out of it. I mean, we're still sort of in it, but we're somewhat coming out of this like horrible war on drugs for the last 70 years. And, in the United States, until very recently, to study cannabis at all, you had to show some harm, or you just wouldn't get funded by the US government. You had to show that it dropped IQ or motivation or sperm count, none of which is true, but so we're just coming into an age where we're more neutrally studying the potential benefits and the potential harms. So I think we're much more set up now to really answer that question. But really, we're still in the infancy, and we just need to get going with all this research.
Thank you so much. I remember even earlier on, Dr. Sandra mentioned about genetical profile studies. So that will be also important, will be a good thing to add on that. Let me ask the other question when I look at the time and we may just run out of time. Let me just go through the question quick. Now that you say the teens should be given cannabis, that goes to you, Dr. Greenspoon, except in autism situation. What will you give teenagers having cancer pain and cancer pains and are in the late stage disease, or those who are having intractable epilepsy and they need cannabis? How will you go about this?
Well, for intractable epilepsy, there's a FDA-approved medication, Epidiolex, so that's easy. As I mentioned before, I am interested in giving it to teenagers, mostly CBD for autism, but we need more research to really definitively prove that. I did mention that I am in favor of giving it to kids with advanced cancer. My brother Danny had advanced cancer leukemia, and it really helped him. So that was one of the caveats that I included. So I actually agree with all of the above. I think that people with advanced cancer, it's just inhumane not to make them comfortable, and you just give them whatever they need to make them comfortable, whether they're a kid or whether they're an adult. I mean, it's also important to mention that we haven't definitively proven that cannabis harms the brains of teenagers. It's thought that it does. The earlier, the worse. So we say just say wait to teenagers because their brains are more developed and they're less susceptible. Some people say we should wait till age 25 because that's when we stop myelinating our brain. But by that argument, we'd have to stop alcohol until age 25. Good luck with that. But also, I think, again, with teenagers and with pregnant women, and we're just beginning to do this, it depends. Cannabis, we need to understand more how harmful it is versus all the other stuff we're giving people, because there are a lot of other drugs that can affect the teenager's brain development. There are a lot of other drugs, if a woman's in severe pain, that can affect her during pregnancy or breastfeeding. So it's not just a binary cannabis is bad for these groups of patients and good for other groups. We have to really understand the specific harms and benefits and especially vis-a-vis the other medications that they're getting. And again, I think there's always been a double standard with cannabis. And a lot of the studies, for example, of cannabis in pregnancy have studied really poor, disadvantaged patients, and they have like lower birth weights, and we don't really know if it's the cannabis or the fact that they're poor or don't have good education or don't have good nutrition. So, and it's very difficult to do this research. You can't just take 1,000 pregnant women and give them cannabis and 1,000 pregnant women and not give them cannabis and see if there are more birth defects. Like, that's not ethical. So we need to do a lot more research, and we need to not have a double standard with cannabis. We need to really study, is it more or less harmful than all these other drugs we're using, for example, for epilepsy in a teenager? Those aren't good for people either. So we need a lot more research, and we need a lot less of a double standard.
Thank you so much. I'll go to the next question. How do you monitor the quality of cannabis, that is CBD, THC, and other cannabinoids you use for the tinctures or other formulation in your practice? And it aligns to the next question. The second question goes like, when do you decide to give CBD versus THC and the percentage compositions with your patients?
Well, CBD versus THC, CBD is low-hanging fruit. It has fewer side effects and isn't psychoactive. And people can take CBD before work. They can take CBD before driving. And for many patients, CBD by itself works really well. So I always start with CBD and see if you can get away with just using CBD, because that's a win. And then I slowly introduce a little bit of THC if the CBD isn't working. And ideally, you want to use as much CBD and as little THC as you can to avoid side effects. Now, in terms of quality, the quality would be much better if the United States federally legalized medical cannabis and they had the FDA or some other regulatory body really evaluating it, testing it, and making sure that the manufacturing is safe and consistent. We have this weird situation in the US. I'd be interested in what Sandra has to say down south, but where it's legalized state by state. So each state is responsible for monitoring what's in the tincture. Is it manufactured well? Does it accurately say what's actually in it? Is the CBD and the THC accurate? We've had real problems with this, especially with CBD. They pull products off the shelf, and some have no CBD in them, and some have way too much CBD, and some have THC in them, which they're not supposed to. So we're sort of at the mercy of the individual state regulation. Some states are much better regulated than other states. In Massachusetts, where I am, because I'm in Boston, the regulation is pretty good. If I give you a 4-to-1 CBD to THC tincture, I think it's probably going to be 4-to-1, and it's not going to have anything else in it. But other states are much more lax about their regulation. And there's also like lab shopping, where people give their product to different labs and then just accept the product that says they have what they want in it, and that's very unethical. So it's a big problem. It varies state to state, and I think the only way we're going to get better at this and at knowing the quality of our products and what we're actually giving patients is if we have federal legalization, the whole country, which we will eventually. I mean, something like 94% of Americans are in favor of legal access to medical marijuana. In every state where it's still illegal, the majority of patients want medical marijuana. So it's absolutely insane that we don't have legalization everywhere. But when we do, that's going to solve the problem of quality control and actually knowing what patients are taking. And I'm wondering what Sandra has to say about all this.
Yeah, absolutely. It's a different situation in Latin America. What we do, of course, there are markets that they are not regulated, and there are people selling it in the streets, in the gas stations. But what I always do, and because in Latin America, what we do is we issue a prescription for the patient, and the prescription goes to the laboratory, and it goes, and then the patient go and pick it up at the pharmacy when it has a THC. Is like a controlled substance, so the traceability is different. But I always do, when I'm prescribing, always prescribe the products that they are have approval of the healthcare system of the regulatory entity that according to different countries in Latin America, for example, in Colombia will be the INVIMA, that is the like the FDA. In Mexico is the COFEPRIS, in Brazil is the Anvisa. So because you want to give your patient the product that you know that it meets the standards and that is a safe product, as we talk, and Berlin talk about this, and we talk in the other modules. The production of these, the chain of production matters, is that you put the seed in the soil until you do the extraction. Every step matters because we are producing medicine. So we don't want to give the patients, as Dr. Greenspoon says, something that it doesn't have the content that is claimed in the label, or even worse, that gets contamination, or that it has pesticides or heavy metals, or sometimes fungus or mycotoxins that can go to the brain, to the patients, for example, with epilepsy or with immune disease. So definitely, I mean, it's a big challenge, as Dr. Greenspoon says, because there is always other markets trying to sell, and people just driven by money, that the only thing that they want to do is sell, and they don't think about safety of the patient. But I always go for safety purposes, and also for the safety of the patients, and for my safety, for liability purposes too, as a physician, with the products that they are validated by the government, that they have like the COAs. But as Dr. Greenspan says, there is now a trend where people is faking COAs. So sometimes you see a COA that what they do is they download it from internet and they put it into the bottle. So you cannot even rely anymore on these things, because there is a lot of people that they don't have ethics, and they're trying just to sell. So in our case, what we want is the best for our patients.
Thank you
Just
so much. The next,
no.
go, Dr. Brilliant.
Yeah, no, I was just gonna say, just very quickly on that as well. We're at the crossroads here in South Africa as well, where they're in the process of now legalizing it for recreational purposes. So it's like kind of like a gray area. So like you're rightfully saying, how do we now know what is the actual one and what is the one that's not coming from someone's backyard and being bottled in people like for money and so forth? I mean, the regulatory authority has really been trying a lot here, because they require you to have your COAs, and we've gotten to a point when we're cultivating, we get the COAs even for the grow mediums, for the water, for our suppliers, whatever they supply to us, we need to know what's in them. And then the final product, we send the bud to the to two places. One, we can do an in-house testing, and then we send it for third-party verification for them to test on the heavy metals and so forth. So, for example, on ours, we found that one of the suppliers had supplied us with a grow medium which had arsenic in it, which is a heavy metal. So it was not acceptable. And then we've got like a lot of mining activities in the areas as well where the medicinal cannabis is being grown. No matter how a closed system is, you still get some contaminants coming in. So I think it's very important actually as well that we work with the governments and the people who set the framework, the laws and so forth, so that they understand that it's very important that we get these laboratories. Perhaps they should be more accessible, because for example here, it's very expensive to just get one test done. You're paying over $200 for just one, to check one. So now if you've got several strains, you can imagine how much you have to spend. So people end up not spending it, like what Sandra has said, Dr. Sandra has said, that people would just download the COA on the website and put in the bottle, because it's actually very expensive as well. So I think it's something that also regulatory authorities, the governments, have got to actually play a big part to it. But we all know who wants medicinal cannabis when there's, you know, the others, which I'm not going to mention. So there's going to be a lot of fight. I mean, we want to push for it because we're saying no to the other stuff that damages your health and so forth. So that's where we are. We're at a crossroads. So we've got to find a field where we can all be players, bring the big farmers on board, bring ourselves on board, and see how we can all work together and get somewhere, because there is just so much resistance, unfortunately. So it is a long way to go, as Dr. Greenspan mentioned earlier, to say we're pushing, but we're going one step and then we're going 10 back. And by now, surely would have made a lot of headways. I mean, the knowledge is there. We know what works. We certainly know what doesn't work, but our hands are tied at some point as well.
Right, and there's the additional problem that is so much cheaper in the illicit market. Like in Massachusetts, where I am, it's regulated and safer, but it's more expensive to make a good product and to test it for fungus, heavy metals, pesticides. And if you buy cannabis, say you buy an eighth of cannabis at the dispensary legally, it's like $60. If you buy it in the illicit market, which doesn't have any of this testing, it's like $30. It's half as expensive. So another big obstacle is that it's more expensive to make a safer product. And a lot of people, like I take care of really poor patients in an inner city primary care clinic and in my addiction clinic that I work at. They're just going to get the least expensive product. They're just desperate for some symptom relief. They can't afford how much more expensive it is. So I guess another big problem is that it is just more expensive to make a good product. And, that just for the disadvantaged patients, that puts them in a really bad situation.
Oh, so let's say we have a good product. Then it leads us to the three last questions. And these are very important questions. And I'll read all of them so that it can be answered collectively as we wind up. Do you participate in any registries or clinical trials related to medical cannabis? That is the first question. Then, how do you navigate the tension between anecdotal evidence and rigorous clinical trials in cannabis research? The third one is, what biases, scientific, cultural, or political, do you think still distort cannabis discourse and use? And the last question, are there areas where you feel the medical community is still failing patients due to outdated cannabis stigma?
Well, that's a lot of questions. I'll see. Wonder what Sandra has to say. The doctors are behind, partially because they believe all these biases, like they still believe in amotivational syndrome or that cannabis makes you dumb or lazy, because we've been bombarded with that by 70 years of the war on drugs. Part of cannabis education for physicians is uneducating them on the stuff that's wrong and then educating them on the stuff that's right. So it's very, very difficult. Because we haven't studied benefits, we've only studied harms, as I mentioned before, in the United States for the last 70 years. We've had to rely a lot on anecdotal evidence. Fortunately, with real world data and with the government becoming more two-sided, we're slowly starting to get better evidence. And I do participate in a few clinical trials, but I'm mostly a clinician educator. So I'm not a big researcher. I have friends that do that. We all do our part. I'm wondering that was my very brief answer to four very complicated questions. I wonder what Sandra has to say.
Thank you. Yeah, absolutely. I agree with you. With the clinical trials, it's very hard to sometimes to do like the transition from a clinical trial to the clinical practice, because when you see a clinical trial, you have to have inclusion criteria, exclusion criteria, and this perfect patient that meets all the inclusion and exclusion criteria are not the patients that we're receiving in the clinical practice. So sometimes, I do believe that the real world evidence is very valuable. Will never be like a randomized control trial that we value a lot, but definitely we just have to find a middle point and gather the evidence that we have in the clinical practice that is very valuable. But definitely we need also more randomized placebo control trial, because this is what we've been using as physicians forever to treat our patients based on this. But knowing that there is very hard to have a patient, as Dr. Greenspan is saying, and I'm really looking forward to read your new book. We have patients that they come with polypharmacy, that they are old, elderly, and then they don't meet all the conditions that they're meeting in the clinical trial. So sometimes it's hard for us when we read a paper, a publication, to say, oh my God, but this patient wasn't taking these other 3 medications that my patient is coming. And those patients, for example, the range of age, it was like from 30 to 50, and then I have a 80-year-old patient. What should I do? So definitely there is like a little bit of situation there, but we've been dealing with this like all our lives with other medicines. So I don't think it's like a big challenge, because as doctors we're learning to navigate this situation. So I think I'm looking forward for more research, and I've seen what Harvard University, Pennsylvania University, Johns Hopkins, and it's exciting to see how they're studying other cannabinoids, flavonoids, and the great work that the Dr. Will have done or is doing with other phytomedicines. So I think that the future is brilliant, that we are just scratching the surface with cannabinoid medicine. I think we're just starting to see all the potential that the cannabinoids have, and also, I mean, assess, as Dr. Greenspan said, always weighing the risks versus benefits. And it's not just with cannabis, it's with every medication. So that will be like a little of the way I'm thinking regarding to this.
Our time is up, but I'll give each one of you 1 minute just to wind up. I'll start with you, Dr. Greenspoon.
Well, thank you for this. Thank you for the education. We need to educate physicians. We need to do all the more research. But part of what makes this entire field so fun and rewarding is helping patients. And part of it's the educational component, a big part. So I really appreciate being invited into like really meaningful and sort of free-flowing discussions like this. So I mostly want to say thank you. And then it's an honor to be on the stage always with Dr. Carrillo.
Thank you for accepting our invitation. Dr. Brelin, 1 minute, please.
Thank you so much for this, and I think we are making a lot of progress. Just very quickly to the question that I was asked about the clinical studies and so forth, there's also the ethics committee, so you can get the subjects for the patients and everything else, and then you get to the part where you need the ethics committee to approve. Is it ethical, is it not? And then that's where also the challenge comes into it, because it's a new kid on the block, so there's just so many obstacles in the way. And I think the more platforms like this we have, the more engagements we have, the better. So I think all this information that we're having on this platform, we need to get it to all the regulatory authorities globally, so that they can have a better understanding, because we're all learning, they're also learning. So they need more of the likes of the people on the platform to actually help them as well. Thank you so much, and thank you to all the participants. Always a pleasure.
Thank you, Dr. Greenspoon. Thank you, Dr. Carrillo, and thank you, Dr. Brelin, Dr. Flory, and everybody, Dr. Arthur, and the technical staff. Thank you for making this happen today. Next week, remember, we're gonna be focusing on safety, risk, and contraindications of medical cannabis. Do not miss. Dr. Carrillo will be there to guide us through this session, to give us more information about this. And please join our YouTube. There'll be more lectures. There's another lectures. There'll be more information, additional information to this that was not presented on this because of time. But join our YouTube. If you don't know, just stay in touch. We shall be uploading the information on YouTube in a few days' time. And then you can, if you have any questions, you can direct them to us. You can direct them to the speakers through YouTube, and then we'll be able to reach you. Thank you so much. Have a great day. Until next Saturday. Bye.
Everybody, bye-bye.
Dr. Greenspoon, it was a
Nice to see
pleasure
you,
to see
Sandra.
you.
Have a good
Great,
rest of the
great
weekend.
panel. Thank you so much.
Bye.
Bye.
Thank you.
Bye.
Great. Bye.